So I'll be going through the data set, and I have to keep to time, as I can see. Obviously, morning tea will break up the session between part one and part two. So we had a working party. We met many times virtually, and we came up with some important data points that we'll be presenting today. So in this presentation, we're talking about an overview of care according to the optimal care pathway at the various stages. We overview the data, the characteristics of the Victorian melanoma population, incidence, mortality and survival, treatment algorithms for stage 1 and 3, care patterns and variations, and the volume of work. So this is the various points of the optimal care pathway. Initially, we'll talk about prevention and screening. The data sets via the linked data sets from the Department of Health, the Victorian Cancer Registry, hospital admissions, radiotherapy, emergency, and the death index, and also unlinked data sources, as you can read. The features of the linked data set: it's a statewide data, it's reliable linkage program, population level outcomes, offers general indicative patterns, but there are limitations to analysing this data. There's no data on community care or clinical trials, no MBS or PBS data for oral examples for oral anti-cancer therapy, relies on hospital coding, which is usually done by junior medical staff, and is driven by DRGs that provide the best income. And we have issues obviously with Albury, where that data is part of the New South Wales data set, even though it's counted as a Victorian hospital. So the registry-derived stage of diagnosis in the linked data set is available from 2018 onwards. It's based on tumour, nodes and metastases, the TNM staging, delivered based on thickness, ulceration, regional and distant metastatic sites. No data on mitoses, Clark level and subsites are also available. It's recorded from the date of diagnosis, metastatic disease determined from pathology and hospital notifications, and in this presentation we focus on invasive skin melanoma as per the ICD code. Just a summary about the integrated cancer services, the ICSAs that we'll be referring to. There's actually a little nuance, I call it the reverse intuitive. So GICS is Grampians and GRICS is Gippsland. So I still get them confused, but just remember the reverse and you'll get it right. Demographics. No real surprises here. The median age is 67. Very small numbers when it comes to Aboriginal and Torres Strait Islanders, and comorbidities, sex, and socioeconomic status are no surprises. Tumour characteristics predominantly level 1 and thin melanomas, again no surprises. I'll be concentrating on when we do have actually statistically significant data in the interest of time. Melanoma site for patients in the linked data set, again no surprises. In females it's more to do with the upper and lower limbs, and in males the trunks. And ulceration status, again known factor that in higher stage melanomas and less in thin melanomas, again no surprises there. So incidence, mortality and survival. The incidence has been rising up until of late. The inflection point, depending on who wants to argue, between 2005 and 2010, probably the results of really SunSmart as a big push 20, 30 years ago. And mortality, again, depending on a debate between 2010 and 2015, there's been a reduction in mortality. Again, the lag effects of SunSmart, but also the advancements in immunotherapy and targeted therapy for metastatic disease. Disparities in melanoma incidence. If You're less likely to be diagnosed if you're the most disadvantaged group, and if in your West Central Melbourne and in northeastern Melbourne, and you're more likely to be diagnosed in the regional centres. But disparities in melanoma 5-year survival rates. There's a better survival in non-Australian born population, but a worse survival in the least disadvantaged and in the Australian born population. Again, no surprises there. So GP screening and referral data has just been presented. I think the main point is that there's less skin checks and biopsies conducted during COVID. That's really the take-home message, which will impact. Stage of diagnosis. We know that earlier stages within Melbourne and more of a higher metastatic stage within regional Victoria. And here we go by melanoma thickness. There's no real differences between metropolitan Melbourne and regional Melbourne between thin melanomas and thick melanomas, with p-values showing no difference, and also between the ICSs. However, important to note that when we talk about that there's worse prognosis melanomas and thicker melanomas in the least disadvantaged, where do the least disadvantaged population live within Victoria? Mostly in regional Victoria and in northwestern areas of Melbourne. Here we have melanoma thickness and stage at diagnosis by socioeconomic status. So remember the previous slide, and this is a highly statistically significant slide where the most disadvantaged would have the least amount of thin melanomas, but more thicker melanomas at presentation and also at stage at diagnosis. MDM meetings, which as you know are the cornerstone of oncology. I always call it kind of the heart of a cancer services unit in any tumour stream. Melanoma, as the data has seen here, has not fared well compared to its other tumour cousins, and that's in the orange boxes, as compared to lung, breast and colorectal. If you look at documentation pre and post-COVID, so the two data sets are 2018 and 2020, the target, that's the expected target, is 85%, and melanoma documentation has been at 37% and 40% respectively, so no improvement. And if you look at in stage, in recording of stage, there's actually been a fall off with COVID. Again, not as good as our other tumour cousins. And quite alarmingly, and probably supporting what our consumers have highlighted in their presentation, is supportive care screening. It's quite exceptionally low at 17% and dropped to 12% during COVID, as compared to supportive care screening, which are far higher with other tumour groups. As an aside, I have found that, not that I'm trying to give you solutions during this presentation, but care coordinators are invaluable at supportive care screening, and they are a big centrepiece when it comes to care coordination, which includes supportive care screening in tumour groups. An example at my hospital, when we had our lung cancer care coordinator piloted it for a year, supportive care screening was at 95%. Funding stopped, screening went down to 5%, which was the impetus for perpetual funding the following year, which has gone up to greater than 90%. The data's there. So treatment. Again, not surprisingly, thin melanomas, most of them are not treated within the hospital setting. Again, for melanomas greater than 1 millimetre, this is showing that they're more likely to be admitted to hospital if they're in a Melbourne hospital, notably SMICS, and less in a regional hospital, notably LMICS. Sentinel lymph node biopsy, not much variation, but again, more likely to be in WICMICS, and IV cancer therapy is basically the same. Time from diagnosis to admitted surgery for melanoma thickness and X of treatment. I think this is interesting data. Red is above the Victorian average and blue is below the Victorian average, and it's at 4 weeks and 8 weeks time of diagnosis. And notably, WICMICS, both at the 4-week and 8-week time point, is below the state average, and with regional Victoria, notably HRICS as well. That is for both thin melanomas, less than 1 millimetre, and thick melanomas, the data translates. Time from diagnosis to admitted surgery for a sentinel lymph node biopsy of X of treatment. Again, very similar, consistent data points, with the time to SNB being at 4 weeks and 8 weeks, within the WICMICS area being longer than that of the Victorian average. And these funnel plot curves just highlight the data presented, with WICMICS, the green dot, being outside the funnel plot. Also, no surprisingly, statistically significant if you get treated within the private sector versus the public sector, your time to surgery is far quicker. This is patient flow for stage 1-3 melanoma admitted for surgery. So if you look, it's taken me a while to kind of figure out this graph myself, this table myself, but the centerpieces are going across is the place of X residence, and either side is leakage into other health services, and most notably is that WIMICs tend to treat their own, and SMICS, while NEMICS and regional Victoria, there's a lot of patient flow into other hospitals, notably WICMICS. And again, this supports that funnel plot with NEMICS being the Metropolitan Hospital outside of the funnel plot with other regional sites as well. So significantly more patients have admitted surgery locally for those health services, but less patients having been admitted locally for NEMICS and those regional health services there. Sentinel lymph node biopsy. This data is interesting. Again, very similar to the surgical data. NEMICS and the regional sites having a lot of leakage outside of their health service, more or less flowing to SMICS and WIMICS. And I thought it was good to compare to the breast tumour cousins who also do a lot of sentinel lymph node biopsy, and that data actually does not translate. So the rate of sentinel node biopsy locally is far higher for both the regional sites and NEMICS sites. So the question is asked, why is melanoma SNB far less than that of breast locally? So significantly more patients having sentinel lymph node biopsy locally at those health services, whilst less patients are having sentinel lymph node biopsy locally at NEMICS and those regional health services, and the funnel plot to support that. This is sentinel lymph node biopsy in both public and private. Melanoma compared to other cancers, which is going to be predominantly breast. It is a small component compared to our breast colleagues. So it's not from really a lack of experience within the health service, I would say. Again, not to say that I want to generate solutions in this talk. Care after initial treatment and recovery. 5-year survival by melanoma stage. Stage 1, significantly poorer survival in LMICS. Again, probably in keeping with the previous data with socioeconomic status. Stage 2, significantly better survival in HRICS. And stage 3 and 4, there's no differences between any of the health services. COVID impacts. There has been a decrease, so the latest data is 350 fewer melanoma diagnoses in 2020 than expected, as per the GP data set. Less skin checks, less presentations. And I've always said telehealth and video conference is good, but not really good for skin checks maybe. Surgery. Melanoma surgery has always been exempt during the pandemic, throughout the pandemic, so you would not expect the data points to change, and I can't see a difference between pre-COVID and COVID when it came to actual surgery. I think it's more to do, the COVID impacts have been at the primary diagnostic stage at the GP and the dermatologist. Consumer identified areas for improvement. Just want to echo the great points made before. The 4 points that identified the need for improved knowledge and management of symptoms and side effects, the need for written rather than verbal treatment and discharge plans, the need for a well-coordinated care and information transfer to general practitioners, and the need for more specialised melanoma nurses. We have a long way to get to be equivalent to our breast care nurses within any hospital setting, I would say. So the second part of the presentation is really to tease out some points from the previous slides. So it's a summary and variations, and then hopefully we can have some further discussion time. And then I think there's, actually I haven't memorised the agenda. I think there's lunch after that. But let's go ahead. So the summary of the and potential unwarranted variations. This first step of the optimal care pathway, prevention and early screening. Mortality rates have dropped for both males and females over the last 5 years. Incidence was increasing, but has reduced in the last 5 years. However, the least disadvantaged more likely to be diagnosed with melanoma compared to the Victorian average. WMIX and NEMIX residents are less likely to be diagnosed with melanoma, and SMICs and regional ICSs more likely. The 5-year survival, the least disadvantaged have a better survival, and the most disadvantaged have a poorer survival. Okay, I usually don't have to be told to speak louder, but I will, as people would know. SMICs demonstrate significantly better survival rates for men, and the Australian-born have a poorer survival rates. The second step of the optimal care pathway, presentation, initial investigations and referral, we know that there's less skin checks and biopsies completed in primary care during COVID, 2020 in particular. That's with the Eastern Metropolitan Primary Healthcare Network, South Eastern and Gippsland Primary Healthcare Networks from the Polar data. The third step of the OCP, diagnosis, staging and treatment planning. SMICs demonstrate significantly lower odds of metastatic disease. GICS, which is Grampians, demonstrates significantly higher odds of metastatic disease. Melanoma thickness, higher rate of thickness greater than 1 millimetre for outer regional and remote Victoria. Higher rate of thickness of greater than 1 millimetre for the most disadvantaged, and higher stage at diagnosis for the most disadvantaged, all consistent, and they're interrelated. Documented MDM rate below the Department of Human Services, and it's also an evidence-based global 85% target. The state average of 40%, which is really the same from the 2018 audit. Lower rate than other tumour groups. Only one campus achieved the DHS target, which was SMICs. Decrease in documentation at stage at MDM. And the supportive care screening, which we know is an important part of cancer comprehensive care, is well below the 80% target. Statewide average at 12%. Significantly lower than other tumour streams. Only one campus achieved the actual target. which is, as you can read. Treatment. Treatment within 1 year of diagnosis at thin melanomas less than 1 millimetre. Surgery in hospitals by ICSA residents. Grampians above the Victorian average, but the other regional sites are below. And at thicker melanomas, that is greater than 1 millimetre, SMICs above average for surgery in hospital, WMICs above average for sentinel lymph node biopsy, and Loden-Malley below average for surgery in hospital and intravenous anti-cancer therapy. Time from diagnosis to admitted surgery through stages 1 to 3, surgery within 4 weeks. Most ICSs are above average. Data indicates WMICs is below average. Surgery within 8 weeks from diagnosis. Most ICSs are average or above, but data indicates that WMICs is below average. The surgery within 8 weeks of the funnel plot show that 3 campuses are below average, with the outliers being within WMICs and SMICs, and 65 campuses are above average outliers by multiple ICSs. Variation in sentinel lymph node biopsy hospital volume ranged from 1 to over 350 sentinel lymph node biopsies per year. So quite a marked variation between hospital settings. Patient flow for admitted surgery. NEMICs and the regional ICSs have significantly less patients having surgery locally. And the patient flow with a sentinel node biopsy are very similar results. We'll have time for questions and comments after these points. These are just, as I said, echoing the slides, the data. Care after initial treatment and recovery. Step 5, the optimal care pathway, survival by stage. Loden-Malley has significant poorer survival for stage 1. HRIX has significantly better survival for stage 2, accounting for the fact that a lot of that data is not accessed due to the fact that it belongs to New South Wales. No statistically significant difference in survival for stages 3 and 4 across all the ICSs, across all Victoria. COVID impacts. There's 350 fewer melanoma diagnoses in 2020 than expected, and a 12% reduction in melanoma surgeries in 2020 and 2021. Interesting data point will be now that we've really entered COVID norm, what's going to happen from now on. And we're just prioritising potential unwanted variations. So the first point, just hold off all comments so I go through them. Some people may not agree or want to add in other priorities. Incidence and survival. Regional areas have a higher incidence and a lower survival rate for less than 1 millimetre thickness, reaching statistically significant in Loden-Malley. MDM documentation rates of 40% are significantly less than 85% the target, and other tumour streams with variation across the ICSs. Supportive care screening documentation rates of 12% are well below the 80% target with variation across the ICSs. And this also has been identified as a consumer priority. There is variation in treatment delivered, again also identified as a consumer priority, in the delivered timelines and local access across the state. There is significant variation in proportion of stage 1 to 3 melanoma patients having a sentinel node biopsy locally, with those health services are less likely to receive sentinel node biopsy locally as compared to others, and in direct contrast to our breast tumour colleagues and breast tumour patients. There is a variation in patient flow across the state, with GRICs, LMICs, NEMICs and HRIX residents less likely to receive surgery locally. The consumer identified potential variations. The need of improved knowledge and management of symptoms and side effects. The need for written rather than verbal treatment and discharge plans, the need for well-coordinated care information transfer to primary healthcare physicians, the need for more specialist melanoma nurses as compared to other tumour groups. A lot of this has been a lot of work by the team within the DHS, Catherine Whitfield and Karen Potting, the Victorian Cancer Registry, the Centre for Victorian Data Linkage, the data analysts Ella and Nora have done a wonderful job. The funders for the Tumour Summits and the Tumour Summit team. And lastly, on behalf of Victoria and I want to thank all the clinicians who attended all the meetings, gave up their valuable time, even though it was virtually. It was always at the end of busy days and providing invaluable information and insights and points that have led to this presentation.